Okay, so let's say you've interpreted an arterial blood gas or an ABG for your patient, and you've gotten down to one of the four main categories of acid-base disturbances, either respiratory acidosis, metabolic acidosis, respiratory alkalosis, or metabolic alkalosis. Let's start with respiratory acidosis. If a patient has respiratory acidosis, this means that their PCO2, or their partial pressure of carbon dioxide in their blood, is too high, which means that for whatever reason they are holding on to their carbon dioxide. And how would a patient be holding on to their carbon dioxide per se? They would do this if they were hypoventilating. In other words, they are not breathing off their carbon dioxide fast enough, and this is what is increasing the pH of their blood and leading to a respiratory acidosis. And so, therefore, the differential for respiratory acidosis would be any number of conditions that would cause the patient to hyperventilate. So, this would include airway obstruction, acute or chronic lung disease. A number of medications such as opioids, narcotics, or sedatives can cause a patient to have a depressed respiratory rate, or perhaps a weakening of respiratory muscles. Now, there's a particular compensation associated with respiratory acidosis. In particular, the kidneys might try to compensate by increasing their reabsorption of bicarbonate, and this is considered to be a delayed response. Okay, so now let's move on to metabolic acidosis. In metabolic acidosis, the PCO2 is normal or even decreased, so the acidosis can't be explained by that. It is instead explained by either some other acidic entity in the blood or by a low bicarbonate concentration. Recall that the calculation of the anion gap needs to be carried out for all cases of metabolic acidosis because this will guide your differential diagnosis and change depending on whether or not it is increased or decreased. And remember, to calculate the anion gap, it is just equal to the concentration of sodium ions minus the sum of chloride ions plus bicarb. Now, if the anion gap is normal, then the differential includes such things as diarrhea, renal tubular acidosis, or hyperchloremia. These particular illnesses will deplete the bicarb concentration specifically. If the anion gap is increased, however, this means that there is some other acidic ion in the blood that is responsible for the acidosis. And so the differential diagnosis for an increased anion gap metabolic acidosis is represented by the mnemonic mud piles. And most of the differential diagnoses that make up the mud piles mnemonic are various types of poisonings, if you will, or ingestions. So the M in mud pile stands for methanol. The U stands for uremia, which can occur in a variety of situations. The D stands for diabetic ketoacidosis, or DKA. The P can stand for paraldehyde or fenformin. The I stands for iron. L stands for lactic acidosis. E stands for ethylene glycol. And the S stands for salicylate. Now, unlike in respiratory acidosis where the compensatory mechanism is delayed, the lungs are able to immediately compensate by hyperventilating. So the compensation is hyperventilation, which is an immediate response. And this is in order to try to balance out the body's pH. And if the lungs aren't hyperventilating appropriately, there might be a concurrent respiratory acidosis or alkalosis. And recall that this is calculated using Winter's formula. And in Winter's formula, I'll just write it out up here. The expected PCO2 is calculated by taking 1.5 times your bicarb concentration plus 8, and then there is a margin of error of plus or minus 2. Now let's move on to respiratory alkalosis. If a patient has respiratory alkalosis, this means their PCO2 is too low, which means that they are blowing off too much carbon dioxide. And so what would cause a patient to blow off too much carbon dioxide? Well, they would do this if they were hyperventilating or ventilating too frequently. And so the differential for respiratory alkalosis would be any number of conditions that would cause a patient to hyperventilate. And so this could be, say, a panic attack, or early in high altitude exposure, or aspirin ingestion. And the compensation for respiratory alkalosis would be the kidneys trying to decrease their reabsorption of bicarb, which again is a delayed response. And now finally, let's talk about metabolic alkalosis. Again, the partial pressure of carbon dioxide would be normal or even increased. So the alkalosis in metabolic alkalosis is instead explained by the bicarb concentration, which can be altered in, say, diuretic use, vomiting, antacid use, or hyperaldosteronism. And unlike in respiratory alkalosis, where the compensation is delayed, here the lungs are able to immediately compensate by hypoventilating in order to try to balance out the body's pH. So the compensation mechanism would be hypoventilation, and this is immediate.